Okay, we're going to try and have class now. If you had previously heard, the past two labs I've tried to have had internet connections. I don't know what's going on with that. So I tried something a little different today, and I decided I would reset my, reboot my computer between classes on the off chance that had anything to do with it, because they always say, turn it off, turn it back on. So hopefully you can all hear me. Hopefully you can all see me. What was happening in the past 2 days was that the audio would disappear, and then the video would jump around, and then it would go off, and then it would come back in. And so after 4 or 5 tries of that, I had to go ahead and pull the plug. Fortunately, we are a little ahead, so we didn't have to. The Monday and Tuesday labs aren't missing a whole lot. We can't catch up on. So anyway, what we're going to look at today is we're going to wrap up the whole section on bones. We're going to look at the joints and the articulations of these joints where the bones come together. And hopefully you can see this. I'm going to go into share screen and joints and articulations. And everybody should see it, I hope. Joints and articulations. Now, in our bodies, we are going to classify the joint movement, or the joint itself, on the type of movement it exhibits. That's what we mean by articulation, when one bone rubs against another bone. And the structure of the joint. What kind of a joint is it? So we're going to look at movement of the joint and the structure of the joint. There's 2 different ways of classifying here. Now, if we look at movement or articulation, where 2 bones come together, we see those in a lot of places here. Now, when we look at articulations, we see there are 3 distinct types of movement. There is no movement, which sounds counterintuitive, but no movement is a type of movement. So the joint can't move at all. We have the slightly movable joint, and we have the freely movable joint, of which those are the most kind in our bodies, the freely movable joint. So the proper term for these are synarthrotic, a joint that has no movement whatsoever. The sutures in our skull are a good example of a joint that has no movement, because we don't want the suture lines where the bones of the skull come together. We don't want them to move. When we did when we were infants and children, because our brain was growing and our skull had to expand to accommodate that. We don't want it now. The mental symphysis, that joint, that structure where the 2 halves of the mandible fuse together and form the one mandible, that we don't see anything except the arrow pointing to the location saying this is the mental symphysis. Well, that's where the bone halves came together. The teeth in our sockets are immovable joints. We like that. We don't want to have our teeth moving around. So they're held in place very tightly. The first costosternal joint. Sternal means sternum. Costo is the another name for the rib. So where the rib and the sternum come together, that first joint is immobile. It doesn't move. Now the second type are the amphiarthrotic, or slightly movable. So you have synarthrotic is no movement. Amphiarthrotic is slight movement. The intervertebral discs have some movement. There is some give in our back, in our vertebral column. The rest of the costosternal joints, 2 through 10, are going to be slightly movable, because our rib cage has a give to it, has a give up and back, up and back. and the pubic symphysis, where the two pubic bones come together in the front of the pelvic girdle. We have that pad of cartilage there at the pubic symphysis, that fibrocartilage. That is a slightly movable joint because that joint will have a little bit of give to it also as shock comes up our femur and spreads around the pelvis. And the most common type of joint in our body is the diarthrotic or freely movable joint. Our shoulder, our knee, our hip, our elbow, the interphalangeals, meaning our fingers and toes, the tarsal bones, the bones of the foot, and the carpal joints, bones of the wrist. These are the types of movement that we encounter. So let's take a closer look here. Synarthrotic, the immovable joint. The bones are only separated by a very thin layer of what we call fibrous connective tissue. It's almost like they're held in place by these fibers. Again, the sutures of the skull are a synarthrotic immovable joint with fibrous connective tissue. The gum fauces, that's the socket of the tooth. Our tooth is held in place by a periodontal ligament. A periodontal ligament is very strong. It's fibrous connective tissue, and it's probably collagen fibers in there holding it there. If you've ever had a tooth extracted, you'll hear some variation on this from your dentist saying, well, I'm going to take the tooth out now. It's not going to hurt, but you're going to feel a lot of pressure because it takes a lot of effort to get that ligament, that periodontal ligament that holds the tooth in the gum fauces, to let go. So that is a immovable joint. We don't want our teeth to move. We don't want our skull to move. And again, there are the sutures here. The arrows should be going over here, but there are the sutures. There's the sagittal suture, and we're looking at the lambdoid suture here at the back of the skull, because there's our parietal bones, there's our occipital bone. Over here, these are the sockets of the teeth, and each tooth is held in place by a periodontal ligament. Slightly movable joints, the amphiarthrotics. Hyaline cartilage connects these bones together. Hyaline cartilage or fibrocartilage. Hyaline cartilage is found in between the intervertebral disc. It is also found at the pubic symphysis. Hyaline cartilage we find at our ribs. Holding our ribs to our sternum is they're attached indirectly to the sternum by hyaline cartilage. And so they are slightly movable. The ribs are slightly movable. The pubic symphysis is slightly movable. The intervertebral discs are slightly movable. Thanks to that, the vertebrae are slightly movable thanks to the pads, the discs between the body of the vertebrae. A couple terms here, a syndesmosis and a symphysis are slightly movable joints. This is a syndesmosis. This is the joint that occurs between the fibula and the tibia. The lateral malleolus of the fibula attaches to the lateral side of the tibia. It's held in place by a ligament, by a fibrous connective tissue, probably fibrocartilage involved here. And we see that this holds the fibula very tightly to the tibia. Now, the fibula doesn't do a whole lot for us. It's probably the most useless bone in our whole bodies. It doesn't do anything. It's not load bearing. Its only claim to fame is it's the bone that gets broken more easily than any other bone, particularly in skiing accidents. And orthopedic surgeons really like this bone because, anyway. The other thing is it forms the outside of the ankle. Remember, there is no ankle bone. The medial malleolus of the tibia and the lateral malleolus of the fibula form the outside of the ankle structure, and they sit on top of the talus from the foot. So the medial malleolus is on the big toe side. The lateral malleolus is on the little toe side. They're held together by this ligament right here. This is a syndesmosis. When we injure the ankle, injure the ankle, it nearly always involves a tearing or a stretching of the ligaments that attach the fibula to the talus or to the calcaneus, especially when the foot rolls over on its side. On its weak side, the outside of the foot is always the weaker side because the fibula doesn't have a lot of strength there. So this rolling over is nearly always what happens. This is a sprained right ankle showing tearing of the ligaments, but there is no ankle bone to break. A break at the ankle would involve the talus or the end of the fibula or even the end of the tibia. So the symphysis is a different type of structure. The symphysis is where we use fibrocartilage. And we have fibrocartilage as the pad between the vertebrae and at the pubic symphysis. So right here where this dark spot is, remember, soft tissue doesn't show up on X-ray. So far we've looked at the back now. We have the synarthrotics, where we are immovable. We have connective tissue holding them together, holding these joints together. Sutures and gomphoses are the movable joints. The slightly movables, the amphiarthrotics, are going to be the vertebrae, the intervertebral discs between the vertebrae, the pubic symphysis with the fibrocartilage pad, the ribs and the hyaline cartilage, the syndesmosis, where we have the hyaline cartilage holding the fibula to the tibia. And of course, we see what happens here with the fibula. Okay, and then we have the symphysis, the slightly movable symphysis. It has to have some give to it. It has to have a little bit of give. The shock comes up the femur, goes into the acetabulum, and the shock spreads around to the pubic symphysis and also back around to the sacroiliac joint. Most of the shock goes up the spinal column and is absorbed by the fibrocartilage pads between the vertebrae. Some is absorbed here in the front at the pubic symphysis. And here are the intervertebral discs. Fibrocartilage pads function as shock absorbers so that we don't feel any kind of pain from shock when we walk or run or hike or bicycle or any kind of activity. Now the freely movable, the freely movable or diarthrotic joints, the knee, the phalanges, the arm and leg, the elbow, the shoulder, the hip, all of these are going to be diarthrotic, freely movable joints. Now the ends of the bones are all covered with a layer of hyaline cartilage to reduce friction. And the ends of the bones where the joint is encased in a joint cavity. They're encased in a joint capsule within which is the joint cavity. They run together sometimes. So you have this cavity between the ends of the bones. The bones don't touch. At a diarthrotic joint, the ends of the bones don't touch. If they touch, they're going to rub. And rubbing causes friction, and friction causes irritation and inflammation and pain. We don't like pain. So the cavity, there's a cavity between the bones, And then this joint is then surrounded by a capsule, which is filled with fluid. And the fluid is called synovial fluid. It's released by cells on the inside of the capsule. And this synovial fluid, which has the consistency of motor oil, heavyweight motor oil, it's thick, it's gooey, it's dense, it's viscous, allows movement at the joint without any friction at all. And so we have a synovial membrane on the inside of the capsule secreting synovial fluid. We also say it's a synovial joint, but it's this fluid that lubricates this joint. So we have all this constant motion at the joint without any pain, without any friction. If we have friction, we're going to have pain. So those are joints by movement: synarthrotic, amphiarthrotic, and diarthrotic. Immovable, like the sutures or the gomphoses; slightly movable, like the pubic symphysis, the intervertebral disc, the joint at the end of the tibia and fibula, the costal joints in the ribs. Slight movement. And then the freely movable are the synovial joints, where we have a capsule around the joint, where we have fluid in the capsule called synovial fluid, where the ends of the bones are already protected by hyaline cartilage, and they have extreme flexibility. And that's movement. Now, by structure, we have what's known as a fibrous joint, or a cartilaginous joint, or we have a synovial joint. So movement-wise, we had immovable, slightly movable, and freely movable. Here we have structure: fibrous, cartilaginous, synovial. Fibrous joints, no joint cavity. We're going to go back to the basics here. The bones are held together by connective tissue, fibrous connective tissue. There is usually no movement or very little movement. They are usually a synarthrotic joint. So a fibrous joint is a joint like the sutures. The sutures are held together, the suture line, the bones are held together by fibrous connective tissue between the bones. So that's considered a fibrous joint. So there is no movement there. They are synarthrotic. If there is a, so there should, there's no movement there. It's a fibrous joint holding the skull bones together at the suture lines. Here's another example of a fibrous joint. The connection between the tibia and the fibula, no cavity, collagen fibers extending across the joint. Collagen, strongest protein in the body, most abundant protein in the body, extending from one bone to another. The skull sutures are a fibrous joint. The teeth with the periodontal ligament is a fibrous joint. The distal radio-ulnar joints at the end, the joint at the end of the radius, where the radius and the ulna are held together, is a fibrous joint. The tibiofibular joint, where the tibia and the fibia are held together right here, is a fibrous joint. Connective tissue, fibrous connective tissue, collagen fibers holding that together. The cartilaginous joints also don't have a cavity. They allow a little bit of movement. The bones are held together by fibrocartilage or hyaline cartilage. Either or. No joint cavity. Now, the epiphyseal plates of long bones. What are the epiphyseal plates? Well, they are the growth plates in the long bones. Now, when we develop in utero, 6 weeks after conception, we are fully formed We're very small. We're maybe an inch long. We're essentially fully formed, and now we're going to grow. We have a complete skeleton in place that is mostly hyaline cartilage, and the rest, like the skull bones, are made out of membranes. But in the long bones of our bodies, our long bones all of our long bones are made of hyaline cartilage, which will gradually ossify, turn to bone over the next 20 years. We retain hyaline cartilage growth plates in our long bones. That's where our bones grow lengthwise from. We call these growth plates the epiphyseal plates. And that's where, up until about age 23, maybe, we're going to see, on x-ray, we're going to see a black line through the bone, because that's soft tissue. Soft tissue doesn't show up in x-ray. That is the growth plate. That's where long bone growth is occurring in all of our long bones, arms and legs, fingers and toes, things like that. Any of the long bones are going to have these growth plates here. So when that closes, that black line, which is simply showing that there's soft tissue, there's not a gap in the bone, it's showing where there's soft tissue. That closes, and it calcifies, it ossifies, it turns to bone, and we have a white line. We call it the epiphyseal line. So the plate between the bones is a cartilaginous plate of hyaline cartilage. Once it stops ossifying and turns totally to bone, then we no longer see the dark area. I'll show you a picture here in a second. The joints on the sternums, we only have one sternum. The costosternal joints, where the ribs attach to the sternum, is a cartilaginous joint. The pubic symphysis is a cartilaginous joint. The intervertebral discs are cartilaginous joints. So we classify, doesn't matter if it's fibrocartilage or hyaline cartilage, it's a cartilaginous joint. We have the synchondrices and the symphyses. So this is a synchondrices. This is where hyaline cartilage attaches the ribs to the sternum. That's an example there. It is a immovable joint, particularly on the number 1 joint. The ribs can give, but the joints aren't going to move. The epiphyseal plate is also a synchondrices. It doesn't move either. It looks like this. This is an epiphyseal plate. On the left-hand side, you see a femur and a tibia and a fibula. These dark lines right here are areas where we have hyaline cartilage that are actively growing. They're laying down bone. This is how children's bones grow to adult stature. So this area here, that dark line there and dark line there, and even on the head of the fibula, because soft tissue, which hyaline cartilage is soft tissue, doesn't show up in x-ray. It shows up as a blank line, blank space. So it's not that there's nothing there. That's a cartilaginous joint right there. Now, after about age 23, where that line has totally ossified, where it has stopped, the hyaline cartilage converts to bone and leaves this white line behind. We call it the epiphyseal line. We see it here, we see it here, and you might even see a bit of it right there on the fibula. We no longer have long bone growth. We have a scar line, a scar there in the bone, or a line it's visible now because calcium is embedded there. It has turned into true bone and is no longer soft cartilage. That is a synchondrices. It is an immovable joint. We don't want to see any movement at that joint, but we have it. We still have it there. So it's a synchondrices because, and it's considered a cartilaginous joint because we have bone and bone separated by a layer of cartilage. In this case, it's hyaline cartilage. This is a good time to bring up a point here. You know, you may have heard the term about being double jointed. There's no such thing as being double jointed. Most people that are double jointed don't have, nearly everybody that is considered to be double jointed doesn't have extra joints. What they have is ligaments and cartilage within those joints that are extra flexible. And so they have this ability to move and bend at angles that most people can't, because the ligaments holding the joints together, the cartilage between the joints, the synovial joints at those junctions have greater flexibility than an average individual. And so they appear to be able to do things like, you know, put their ankles behind their neck, or, you know, bend the end of their finger down and leave the rest of the joints at the knuckles straight in a straight line. The ligaments and capsules are extra stretchy. We say double jointedness, but there is no such thing. It's also a good time to point out that arthritis, inflammation of the joints, will affect about 95% of us. 95% of the population will develop arthritis. And I can tell you this, that cracking your knuckles does nothing to enhance arthritis. Cracking your knuckles makes the joints feel good, but it will not cause arthritis later in life. Arthritis, osteoarthritis, which most of us are going to get at some point or some version of it, is simply is arthritis caused by wear, and arthritis is inflammation of bone. Osteoarthritis is the term we use for the standard, inflammation, irritation. It hurts to move your fingers or something like that. 95% of us are going to get it because that's wear and tear arthritis. Cracking your knuckles does not cause wear and tear. Cracking your knuckles does not cause arthritis. It's an old wives' tale, as they say, that if you crack your knuckles, you'll get arthritis. You're going to get it anyway. 95% of us are. And it has nothing to do with whether you crack the knuckles. When you crack the knuckles, you're releasing pressure in the joint, air pressure. And that's not going to cause arthritis because you're not increasing the friction in the joint. Okay. So those are the first two types of joints. We have the cartilaginous. We have the fibrous connective tissue, the fibrous joint, the fibrous connective tissue, the cartilaginous, either hyaline or fibrocartilage. Now we have the third joint, the synovial joint, also a freely movable joint. The bones are separated by a cavity. The cavity is lined by synovial membrane, which secretes synovial fluid. That fluid has the consistency of heavyweight motor oil, and so it creates this viscous surface here to lubricate the joints. And so we have a great range of motion at the joint without any friction. We see it at our shoulder, our hip, our elbow, our knee, the bones of the wrist, bones of the ankle, and all of the phalanges. So here we see, and this is actually two phalanges coming together. And there's the cavity in here. The blue stuff is the hyaline cartilage covering the ends of the bones so they don't rub together. Because rubbing together causes friction, and friction causes inflammation, and inflammation causes pain. We don't like pain. The green layer here is what we call the synovial membrane that makes the fluid in here. And so we have our bone here and our bone here. These are long bones. And at the joint where the long bones come together, we have a joint capsule that surrounds the cavity. And then we also have our ligaments that attach the phalanges one to another. So we use a lot of ligaments to attach bones to each other. Now, this is a synovial joint at the shoulder. Now, this is a very complicated joint. But we can do great things. We can rotate our arm around the shoulder almost at a full 360 degrees. Now, that joint capsule is very large because it has to surround the head of the head of the humerus and a portion of the scapula and a portion of the clavicle to give us this range of flexibility. So, but we have this incredible range here. And this is, synovial joints are freely movable. You can bend them in different directions. At the shoulder, we have this tremendous range of motion. In a lot of places, we have even more complications added to the joint. Now, the knee is the most complex joint in the body, and the hip and the shoulder aren't far behind. We will tend to cushion the synovial joint. In addition to the capsule and the fluid, we also have where the bones come together. In addition to the hyaline cartilage and the joint capsule, we often have pads of cartilage separating the ends of the bones. The fibrous capsule is often protected by this pad of cartilage. We call this the meniscus. Here we see a meniscus here and here. And if we're looking down here, this on top of the tibia, here is the medial meniscus. Here's the lateral meniscus. It's a pad of cartilage to function as a shock absorber and to stabilize the joint. We all have these pads in our knees. This fibrocartilage is going to stabilize and cushion our joint. We have these menisci at our knee, at our jaw, and at the sternoclavicular joint, where the clavicle and the sternum come together at the clavicular notch. There are pads of cartilage right in there. Now, something else we have are sacs of fluid, synovial fluid. It's like a water balloon filled with synovial fluid. The synovial fluid in here, this sac of fluid is called a Bursa Sac, and we place the Bursa Sac anywhere where we're going to have friction from ligaments rubbing together, ligaments rubbing on bone, bone on bone, muscles on muscle, tendons on tendons, and ligaments on ligaments. Carpal tunnel, the sheath of ligaments that run down our arm. The covering on these ligaments is a large Bursa Sac wrapping around these ligaments that allow our hand to move. Overuse of those ligaments can cause the Bursa Sac to become inflamed. And when the Bursa Sac is inflamed, we say it's carpal tunnel. And it usually hurts all up and down the arm. It's caused by a repetitive motion. It occurs again. Repetitive motion occurs over and over and over. It's a repetitive motion injury when you have carpal tunnel syndrome or an inflamed carpal tunnel. It used to be called tennis elbow because in tennis elbow tennis elbow is caused by repetitive motion. Person plays tennis, the backhand is going to be repetitive. It's going to be the same type of angle over and over again. Painting, particularly if you're using a roller and you're painting over your head and you're going up and down, up and down, up and down, up and down, over and over and over again for hours, that will cause inflammation. A person who spends a great deal of time at the computer may experience carpal tunnel. Again, any kind of repetitive action that goes on for hours and lead to inflammation of those bursa sacs. Or pressure. Pressure can cause inflammation on the bursa sac. You know, it can occur at the shoulder, it can occur at the elbow, it can occur at the knee. You know, there's numerous places where a repetitive action can cause this inflammation. So here we see the bursa sac at the knee. You know, the bursa sac here, right here, looks fine. And there's the knee, there's the patellar tendon. The bursa sac is in here. Now we see the bursa sac inflamed. The whole area that's lit up white is inflammation of the bursa sac. Something, you know, an injury, constant pressure on that knee. A roofer, if they're or someone, you know, someone who works a lot and puts pressure on these, someone putting down flooring may develop inflammation of the bursa. Someone, you know, maybe a cable installer, maybe someone running computer wiring, someone working, a roofer, someone who spends a lot of time where there's a great deal of pressure constantly put on the knees. You know, there used to be a condition years ago when floors in buildings were scrubbed by hand, you know, by you know, the janitorial service at night, usually women, and they used to call it housemaid's knee because of, you know, it would occur mostly in women that were scrubbing their floors by hand, and if they worked, if that was their job in you know, janitorial service usually worked at night in the buildings, cleaning service in cities, and lots of women did this up until, I don't know, the 1940s or 50s, and 8 hours a night scrubbing floors on your hands and knees caused inflammation of the bursa. So, and the disease, and the condition was called. It was one of the first It was a new type of occupational injury. It was called housemaid's knee. So hopefully we don't see a lot of that anymore. But any kind of activity that inflames a bursa sac will cause bursitis. And that's what happens. Okay. Now our knee, as I said, is the most complex diarthrotic joint in the body. It is the largest freely movable joint in the body. It has a partial capsule. It doesn't cover all the way around with the capsule. The capsule only covers the sides and the back. The front is not enclosed with the capsule. There are actually 3 joints coming together: the tibia and the femur, and the patella and the femur. So you have the medial femur and tibia, the medial femur and medial tibia, the lateral femur and lateral tibia, and you have the patella and the femur. So these are 3 different joints coming together. You notice that the fibula over here doesn't get anything. It just is sort of hanging on. It's attached here by a lateral ligament over here in the side. But the 3 joints involved here are the ends of the tibia, the ends of the femur, and the patella itself. Knee movement is a hinge joint. You know, where our knee is designed to pivot on the hinge. It has a little bit of sliding, not much. It can slide forward a little bit and backwards a little bit, but not very much. It's not designed to. And this shows you some of the structures. And here, this is a meniscus. That's the other meniscus. The meniscus is a pad of cartilage designed to protect and insulate the end of the femur from the end of the tibia. It's a shock absorber. Here we see one of the most important ligaments in the knee. This is called the Anterior Cruciate Ligament, or ACL. This is to prevent sliding motions from taking place. The ACL attaches to the front of the tibia and to the back of the femur. That's why we call it the anterior cruciate ligament. Its counterpart is the posterior cruciate ligament, which attaches to the posterior portion of the tibia and the anterior portion of the femur. They cross over. That's where the term cruciate means cross. They cross over here. So the posterior and anterior ligaments are designed to prevent a lot of movement, sliding movement of the knee. It's often damaged in contact sports, because in contact sports, our knees sometimes we try to make our knees do things that they're not supposed to be able to do. That usually only happens once. There's the ACL. There's the patella, the patellar ligament, right there. And what we don't see are what are not labeled are the medial and the lateral meniscus. I know it's the lateral meniscus because it's on the side of the fibula. The fibula is always on the lateral side. The tibia is always on the medial side. So now let's take a closer look here, explaining what the ACL and PCL do. Now we're looking at the front of the knee, right here in the illustration. The ACL connects the front of the tibia to the lateral, to the back of the femur. So it starts on the lateral femoral condyle, starts in the back of the lateral condyle. Remember the bulge that goes up and down. The lateral condyle on the femur and extends to the front of the tibia. The PCL connects to the back of the tibia and connects to the front of the medial condyle of the femur. So they cross over. See, this one's going from front to back. The ACL goes from front to back, and the PCL goes from back to front. They cross over each other. The ACL keeps the tibia from sliding forward. The PCL prevents the femur from sliding forward. Sliding is not a good thing. Okay. A tear in the ACL nearly always requires surgery. There's our ACL. Okay, we're looking here from the back side. The ACL attaches here on the lateral condyle. This is the lateral condyle here because it's on the outside, and it's the ACL attaches in the back there and it inserts on the front. This is the PCL attaching back here and going to the front. So, and they cross over. This is an ACL tear right here. Again, we don't want the bones to slide. We don't want our bones to slide. We don't want the tibia to slide. We don't want the femur to slide. Okay. So now here's a reasonably healthy looking knee. We're looking at it from the posterior surface. Here is the medial condyle. There's the lateral condyle of the femur. There's the medial condyle and the lateral condyle of the tibia. There's the medial meniscus and the lateral meniscus. Let's put some labels on this. Femur, posterior cruciate ligament, and where it starts starts in the back and goes to the front. There's the lateral collateral ligament, or the fibular collateral ligament, that attaches the fibula to the femur. There's one over here too that is the medial collateral ligament, or the tibial collateral ligament. That's this one here, which attaches the tibia to the femur. Lateral meniscus, fibula, tibia, medial meniscus, tibial collateral ligament, or medial collateral ligament. Because remember, the tibia is always on the medial side. Okay. Again, we see there's our fibular collateral ligament or lateral collateral ligament. You know, that ligament is all that's holding the fibula to the femur. Patellar ligament with the kneecap inside of it. There's the tibia. There's the fibula. The lateral collateral ligament, or otherwise known as the fibular collateral ligament. Femur. Now let's get back here. And again, there would be another ligament on the other side. This is the lateral meniscus. The medial meniscus is next to it. The ACL and PCL are in that area, right up in there. Now, when our knee dislocates, it usually slides forward or backward, and we can push it back in place. Generally, though, if the knee dislocates, it's probably damaged the ACL or the PCL. But surgically, we can repair it, and it takes 6 weeks or so to recover from that kind of injury. So, now, why do our knees hurt? Well, our knees are hinge joints, and the ends of the bones wear out. Over time, the synovial joint may fail. The hyaline cartilage that protects the ends of the bones gets worn away and exposes bone on bone. Bone on bone movement causes friction. Friction causes inflammation, and inflammation causes pain. So when we have a knee replacement, what do? Well, it's a pretty straightforward process. You cut out the inflamed or damaged tissue and replace it with artificial components. There, for example, there's the, we can see right now we're putting in the meniscus. Remember, the meniscus pads sit on top of the tibia. So what we're doing here is if the ends of the femur, for example, are inflamed and worn away, and the ends of the tibia are inflamed and worn away, we remove the damaged tissue. We put a new covering over the end of the femur, that metal plate that goes over there. We put a new condylar surface on the tibia, essentially on the femur too. There goes the condylar surface. We put the new condylar surface on the end of the femur, the artificial meniscus, and then we fasten the patella here, and our knee works. And individuals who have knee replacement, it's a change in life quality surgery. It improves their life quality so dramatically. Once we have the knee replacement, we have the, it really only involves 3 parts: the femoral component, which contains the replacement condyles, the tibial component, which are the condyles for the tibia, and the plastic spacer, which doubles as the meniscus. And so it looks like this, and we haven't removed these ligaments. These ligaments are still attached to the tibia and to the femur, tibia to femur, and fibula to femur, and there's our patella right there, still in its patellar ligament. Hip replacements, a little different, but similar type procedure. The head of the femur inside the acetabulum gets worn. It gets worn and it gets inflamed, and it hurts to move. It becomes fragile. In many cases, this leads to a hip fracture. Hip fractures occur between, the most common hip fracture occurs between the head and the greater and lesser trochanters. In other words, the neck of the femur. The neck of the femur is where the fracture usually occurs. That is where most of the bone underneath the outer covering of bone is all that remains. the bone underneath the outer covering, the inner bone, what we call the spongy bone, has been dissolved away through osteoporosis. So all you have left is just a thin outer shell of what we call compact bone. And that bone breaks. It breaks easily, usually occurring in older postmenopausal females because they're not producing enough estrogen to stimulate bone growth. So grandma sneezes and breaks her hip. Grandma coughs and breaks her hip. She rolls over in bed funny. She breaks her hip. She trips on something plastic. She trips on a throw rug on the floor and falls down and breaks her hip. But it can be any cause. And conventional wisdom 60 years ago was that to repair the fracture involved rebuilding the joint, packing new bone cells in around the joint, and putting grandma in a cast, a body cast from the waist down for 6 months, and let the bones grow back together again. And the mortality rate on that kind of procedure was extraordinarily high, because you put grandma, 80-year-old female, she's gone through surgery to repair her hip. So she's already been traumatized from that. So she goes through surgery, she's in her hospital bed, and after about a week or so, she has a pretty good chance of developing pneumonia because she's flat on her back and she can't cough and clear her throat properly. So she aspirates saliva into her lungs, which drags down bacteria, and she develops pneumonia because of aspirating fluid. And because she's 80 years old and she's weakened already from her procedure and her trauma of the injury, she gets pneumonia and she can't fight it off. She doesn't respond well to the medications and she dies. So usually a week or two after breaking her hip 60 years ago, grandma would be dead. Now, the patient is brought in with a broken hip. She's taken to surgery. She's already been traumatized once. So let's not traumatize, let her rest and traumatize her again. She's taken to surgery. The broken end of the bone is removed and an artificial hip is inserted into the shaft of the long bone, and an artificial acetabulum is in place. It's super glued and wired into place. And the next day, or maybe the day after, grandma is up and around. She's forced to move and walk around. And in 3 or 4 days, she's out of the hospital. And she doesn't die from pneumonia. And she's out walking around with her walker. And then in the following week, cane, and the week after that, she has total mobility. And her quality of her life has improved drastically. So again, hip replacements are right up there with knee replacement. And it involves this, this is an artificial hip. The stem goes down inside the femur. There's a liner over the head. And then we have to replace the acetabulum too, because the old head is worn, the acetabulum is worn down too. So we can't put a brand new head of stainless steel or tungsten right into a worn cavity. So we have to put a liner in there too. And we get complete freedom of motion, probably adding 20 years to your patient's life. So here we see, what it looks like. See how far, we cut off all the way past the trochanters, and we run this down the shaft here, and seriously super glue it and wire it in place, and it works, and it works very, very well. And that is joints and articulations with a little special emphasis on the knee and the hip. Out of here. I hope everybody heard that. So if it did, then I guess the problem is solved. I don't know why my internet was so sketchy the past 2 days. So, anybody have any questions on anything? Okay, then I'm going to get this out of here. We are done with bones. Next week, what I will do is, so next week is the 6th. of October, I guess, we will have a review of all the bones. There's a video that I had, I'm going to show you, and it's also embedded in eLearn that you can watch it as frequently as you want. And then, you know, give you a little more time to get ready for the bone test. We'll have fall break on the 11th and 12th. We won't have labs that week. And when we come back from fall break, it'll probably be I'll probably open up the bone test then. So anyway, I'll have to look at the calendar to make sure I have that set right. So, and I will see you all later. So have a good rest of the day.